Well, good evening, everybody, and thank you so much for taking the time to join us this evening for our webinar entitled Innovations in Hematology. And I think this is the fifth year that we've done this webinar, which has really been a great thing um, for all of us here at Moffitt, but also for our audience to learn more about some of the latest and greatest treatments and research going on in the department. I'm Dr. Jeff Lancet. I am the chair of the Department of Malignant Hematology here at Moffitt, and I've been fortunate enough to really be able to oversee a department that is um, uh, really at the cutting edge of so many different novel therapeutic research projects and basic science and translational research. And of course, patient care is cutting edge here. And I'm really happy to be a part of this entire program that's been so successful over the last several years. And I'm really excited also to introduce to you my colleagues who will be presenting tonight. Um, and I think you'll find a lot of value and that there should be a lot of interest in the information that we share with you all tonight. But before we start, a few housekeeping items. Please note that this content is not intended to be medical advice and that viewers should consult their physician if they have any questions. And please don't rely on information contained in this webinar for any immediate or urgent medical needs. In addition, if you think you might have a medical emergency, call your physician or go to the nearest emergency department or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation. So again, we're very, very happy to have everybody with us tonight. I think we have a really large group, and we have an outstanding panel of speakers representing our program. But before I introduce them, I just want to remind everybody that after the presentations from the speakers tonight, we will have a question and answer session that will allow anybody in the audience to ask questions via the Q&A box that is at the bottom of your screen. So please submit your questions, and we will make every effort to answer those questions in real time as they pertain to each field that we're discussing. So in our department here of malignant hematology, we have three different disease-based sections. We have the myeloid section, which focuses on myeloid diseases. We have the lymphoid section, which focuses on the lymphoid diseases like lymphomas. And we have the myeloma section, which focuses on multiple myeloma and other related plasma cell diseases. So we have faculty members from each section speaking tonight to provide you with the latest updates in clinical research and treatments. And I'm going to start by introducing Dr. David Salman. And Dr. Salman is the chief of the myeloid section here within our department. Dr. Salman is an associate member, an associate professor within the Department of Malignant Hematology here at Moffitt, and has really led very outstanding clinical trials that are really mechanism-based and have provided a lot of great knowledge for the development of large-scale clinical trials. And Dr. Salman tonight will be giving us a brief overview of one of his interests, which is the ability to diagnose and treat precursor conditions or myeloid diseases before they really become full-fledged leukemias and other related myeloid diseases. So Dr. Salman, thanks for joining, and take it away.
Perfect. Yeah, thanks very much for the introduction. It's really a pleasure to be back here. I think I was here either last year or 2 years ago. So I really want to take a couple of minutes and really highlight just some of the great work by our department as a whole. Again, we, from a volume perspective, probably treat somewhere in the top five as far as total numbers of patients with myeloid malignancies, with encounters into the thousands. So we are really not only trying to offer the most, cutting edge clinical care, but really offer the new therapies and help spearhead those as far as really changing how the world practices. So I just want to kind of highlight really just in this past year, some of the sort of great things that our department, again, really proud of all the faculty members, within it. So for just to kind of start, for lower risk myelodysplastic syndrome, we have our first, or we had one approval this last year, and that was a first in class and first in human agent called imetelstat, which is a telomerase inhibitor. And essentially, our telomeres kind of produce our or protect the length of our chromosomes. Actually, I think a lot of people wanted to get into this field originally because if you could block this, maybe none of us would get old. Of course, that would be a very lucrative agent. But actually, what they found is it could restore the ability to make red blood cells. And actually, Dr. Kamrachi in our group has really been a pioneer in low risk MDS therapies. And ultimately, he was actually at the ODAC, which essentially is sort of the council that guides the FDA on approval or not. And it was really kind of his discussion, as well as one of our patients at Moffitt who had a really amazing response, on the agent that ultimately led to the approval. It was actually a little bit of a contentious review committee, but really it can, offer a response for patients that don't have other therapies, and the magnitude of the benefit with this agent when it works is quite impressive. So we have a lot of goals to further understand this. We are kind of pitching a sort of cutting edge translational and clinical project looking to have biomarkers for predicting which of our patients may best respond and to really better understand the mechanism of this agent in our patients. Similarly in MDS, and kind of highlighted on the bottom left, is I've in particular had a lot of interest in sort of targeting the underlying inflammation pathways that drive myelodysplastic syndrome. We know this is a very inflammatory disease. And so we led one of the first investigator-initiated trials, canakinumab, which is an interleukin-1 beta. We're still actually enrolling for really a focused subset of patients, although by and large, we've not really seen enough activity, I think, for that to move forward, maybe outside of very specific circumstances. But there's a lot of different targets in this pathway that we really can hope to not just improve blood counts, which has really been what we've done to date in lower risk MDS, but to change the natural history of these patients, to improve survival, to prevent the chance from getting leukemia. And so there's a number of targets, NLRP3, IRAK, and others that we're helping to hope lead. And I think these are going to be some of our key trials overcoming or up and coming in these next years. Dr. Kirkendale, who really pioneers our MPN efforts, we are really have been one of the 2 or 3 lead centers and really leading the current phase 3 effort for an agent called rusfertide, which the goal is to eliminate the need for phlebotomy or taking out blood in patients with polycythemia vera. This not only has a big impact on burden for patients, but keeping people at optimal control can decrease risk of strokes, et cetera, from that. And again, we're hoping that this trial will read out positive in 2025 and will be actually our first new approval in many years for patients with polycythemia vera. He's also looking to change the natural history or the frontline landscape. There was a really pivotal phase 3 trial that we were a part of, and he helped lead from our center, where we're combining with JAK inhibitors, which is essentially what we've had for a long time, with newer drugs. And so although this trial was slightly negative, we're actually still hoping that there's a path to approval, and he's helping to lead some of those efforts to bring that about, as well as the fact that we have actually pretty much a trial for any MF patient at this point, both frontline, second line, and others, to improve outcomes. In the field of AML, just briefly, we're really, we've had HMA, or what are called hypomethylating agents, azacitidine or decitabine with venetoclax, which is our frontline therapy for patients that have older acute leukemia. And so we're really looking to improve that, and particularly for patients that don't have mutations that we can target. And so there's a very exciting technology called pivekimab, which is essentially an antibody that brings a payload with it. So the cancer cell kind of, not smart, eats the antibody, and ultimately the chemotherapy is targeted. And particularly in frontline, we've helped lead these efforts, and we're really hoping that we can have a pivotal phase 3 trial. This agent, we're actually hoping to get approved maybe by 2026 for a very rare type of blood cancer called BPDCN from that perspective. And then lastly, just 2 other things to highlight. I think in older acute leukemia, again, patients need therapy technically for forever. And that's a huge burden on patients, and takes away from many other things that they could do. So we're really excited. Can we stop treatment? And there's kind of growing data that's highlighted in the survival curve that suggests if you're in a perfect remission, and we are continuing to increase or improve the tools for this, that if you stop, patients may be able to have very long remissions, and maybe some of them are even cured. And so Dr. Chen in our group now has opened, and we're, have one of the two trials in the world here and in France, where patients who are perfectly in remission at 12 months, we're actually going to watch extremely close, and then see how patients can do. And then lastly, we really hope to bring kind of the first immune therapies for patients with myeloid malignancy. I think you're going to hear from the next two speakers really amazing changes in the standard of care based on this type of work. We're not there in myeloid, but it's not without trying. We've actually treated more patients with CAR T with myeloid malignancies than any other place in the world, but we are looking to kind of bring the most novel targets and have some exciting new options that are going to be in clinic, some now and some a little bit later in 2025. Next slide. And so a little bit briefly, I just want to highlight two. One, from the title is, again, can we really catch patients before they ever get cancer? And if we can we predict who's going to get a problem, who's not going to get a problem? And, ideally, if we think somebody's going to get a problem, can we do something about it to prevent it? So we have this very catchy Catch Clinic named by our esteemed chair, Dr. Lancet. And really what we have, actually, we've had a faculty now here for several years, Dr. Shi, really a world expert in this area, and actually one of the two main systems to prognosticate what the risk is. She just published in Blood a really high impact paper. And so this clinic is up and running. So we're really looking to catch or to evaluate patients getting chemo, especially high-risk populations, patients with breast cancer, older patients getting chemotherapy. And again, we have this really nice multidisciplinary team to then predict, okay, this patient really not much, or this one really clearly needs to be evaluated in our clinic. There's actually other issues such as heart disease and many other problems when you pick this up. And we really, have this nice system where we can really hope to not only give a prognostic discussion, maybe what is the role of adjuvant therapy, but ideally, again, coming up with novel therapies to improve how these patients can do. Next slide. And so these are just some of the big goals. It's, again, really to have sort of the largest clonal hematopoiesis repository and patient volume from that perspective. So we're really hoping to increase this really exponentially. Again, this is a multi-team that we're bringing in more and more people with expertise, particularly cardio-oncology from this perspective. And we're hoping to have a really excellent and next level grants with, again, multiple groups, again, really to, again, have the goal of preventing cancer, which is really the mission of Moffitt Cancer Center from that perspective. And again, we are just in 2025 going to have some of the first trials ever for treating patients, one of which is with that inflammation inhibitor that I talked about on the slide before. Next slide. And so there are some needs here. We need more designated clinical space. We really need a lot of funding for some of the translational work that is pitched. And the problem is some of these agents really aren't cancer agents. So this is a cardiovascular drug that has improved survival. So it's within internal medicine, but we have really strong data to support its indication. And so we've already kind of written a protocol and really looking for funding. Again, it's unfortunately very expensive to run these type of studies. Again, typically about minimum $10,000 to get one patient on study. And so we're looking to fund these because these are things that pharmaceutical companies may not have as much interest, but we really want to pioneer. Next slide. And just with my last couple of minutes, I can't have a presentation that I give without talking about TP53. And maybe some on the call are very much aware, but it's really the mutation out of all mutations that predicts for, unfortunately, the poorest outcomes, the lowest chances to be cured, the lowest durations of remission. And I would argue in all of cancer, this mutation in this subset is really the worst disease that exists, worse than metastatic pancreatic cancer, as an example. And so we've done a lot over these recent years to really identify, how do we prognosticate these patients? There are a small subset that may not be as adverse, and really coming up with guidelines based on standard of care to optimize therapy. And really what I tell all my patients is we try to be out of the box at every time point in order to ideally improve outcomes. This is a nice paper published in Blood just this past year, kind of highlighting this. But you could see the options that we really would like are clinical trial, clinical trial, clinical trial. Next slide. And so we actually led the first ever P53 specific trial. This went from phase 1 all the way through phase 3. It's a first-in-class P53 reactivator that really had exciting data in phase 2 and was so close, but just barely missed phase 3. So we're really actively trying to resurrect this. This is another thing where, again, if we have funding, we can run these trials on our own. Next slide. And so along these lines, Dr. Berjona in our group, who leads our translational work, we basically had patient samples and also these really novel cell lines where we can look at really the only difference in these being the presence of P53 mutation. And he was actually able to identify why patients become resistant. And this is an XPO1, which I know are just a bunch of letters, but essentially this is another thing that we can target. Really strong clinical rationale. Actually, the company that makes the XPO1 inhibitor is fully supportive and will give us drug, but we really just need funding in order to make this happen. And potentially in end of 2025, if we can get the funding for this, we could again really potentially come up with the first P53 specific therapy to date. There's actually a next gen inhibitor for a very specific reactivator that we may bring to our center later this year as well. Next slide. There are some potential other ways to reactivate. One of this is actually with arsenic, which has been a curative therapy for a rare type of acute leukemia called APL. And so we're working closely with this company, trying to validate if the mechanisms are the same and potentially bring this agent for our P53 mutant patient populations. Next slide. And so really, in conclusion, and thank you for listening, our goal is really to have one of the largest, if not the largest, investigator-initiated portfolio, really coming up with new therapies that we think may most optimally change the standard of care for our patients. Again, there's big funding challenges. Pharmaceutical companies have really greatly limited some things over recent years, and they have very focused efforts on, certain drugs and trying to get them approved, but this may miss lots of patient populations. And our goal really is to have a trial for every patient. So with that, I thank you for listening. And again, we have a really great team at Moffitt and some outside collaborators that contributed to some of the discussion. Thank you.
Thank you so much, David, and really exciting work that has translated into the clinic, both in terms of treatment of active disease, but really exciting to think about all of these strategies that we can deploy towards preventing disease based on the knowledge we have about these precursor conditions. So great presentation, and Dr. Salman will be on for questions and answer a Q&A session a little bit later on. Next, I'd like to introduce another prominent faculty member here in our department, Dr. Seme Gabala, who is an associate member and associate professor here at Moffitt Cancer Center. He is working in the lymphoma section, and Dr. Gabala has also a lot of expertise in early phase clinical trials in lymphoma, and one of his interests is related to immune therapy for this disease type. And one of the most cutting edge and exciting areas of immunotherapy involves these very novel, what they call bispecific antibodies that really help to engage the immune system in allowing for response to these therapies for refractory lymphomas. And Dr. Gabala is going to be talking to us briefly about some of the updates in these bispecific antibody treatments and some of the new clinical initiatives going on here at Moffitt that support these programs. Thanks, Seme.
Thank you, Jeff, and it's a pleasure to be here. Again, my name is Sam Gabala. I'm an associate member at Moffitt Cancer Center here. So I'm going to review with you some of the directions and cutting edge technologies that are being utilized in patients with lymphoma. Now, we've had CAR T-cell therapy now approved. The first one was approved in 2017. And what that is there is one cell in your body called T cell, and that's part of your immune system. And T cells, they don't only fight infections, they actually have the capability to fight cancer cells, and that's one of their functions. So for a variety of reasons, sometimes cancer cells escape the immune effect of T cells. And the question is, how do we harness that power to fight the cancer cells? So one approach was CAR T-cell therapy, which again, Moffitt is one of the leading institutions administering these types of treatments, and we led a lot of the trials that led to the approval. Dr. Fred Locke, Dr. Chavez, they really had a very leading role in CAR T-cell therapy, approval in the United States. And what that is, so we basically have the patient donate their own T cells, And then through a process of genetic modification, we basically have those T cells express a sensor on the outside, and then expand them. And then we give them back to their patient. And now with this new sensor on the T cell, they could now identify the cancer cells and actually go and kill them. It's a complicated process. It's expensive. It takes some time. It is associated with some unique toxicities. But again, it has offered curative intent treatments to a lot of patients with lymphomas who otherwise would have been incurable before. Next slide. So now the next wave of therapies coming to lymphoma is what we call bispecific antibodies. Again, we're here redirecting the power of the immune system. So the thought is, instead of taking the patient's own T cells, modifying them, putting them in their putting back the modified CAR T cells in the body, no, we're going to administer an antibody that has two ends to it. One end will attach to your T cells inside the body. The other end will actually attach to the cancer cell. And this target could be, different. So it could target B-cell lymphomas through different targets. It could target multiple myeloma. It could target solid tumors. So, basically it's bringing the T cells inside the body to the target that you're trying to kill. And next slide. So this is as a presentation here. So you have on the right side, this is the T cell. It has the CD3 receptor. Right now, it does not have the ability to fight the cancer cell, which you're seeing on the left-hand side. And next, we're introducing here the bispecific T cell engager. And as you see next, basically it's bringing the two cells close to each other, binding both. And once the cells are activated, then they release these granules that, have materials that basically kill the cancer cell, as you're seeing in front of you. So this is basically a simplified, animation of how those bispecific antibodies work. Next. And this is the current landscape. So mosunetuzumab is currently approved in follicular lymphoma. Glofitamab is approved in diffuse large B-cell lymphoma. Epcoritamab is approved in follicular lymphoma and diffuse large B-cell lymphoma. A lot of these approvals were because of trials that Moffitt has been a leading institution is. Dr. Chavez here at Moffitt Cancer Center has had extensive work with both mosunetuzumab, epcoritamab, and glofitamab as well. And we still have ongoing studies looking at not just the bispecific antibodies on their own, but actually combining them now with other agents to try to increase the effectiveness. There's ongoing studies. I'm the PI on a study looking at a different target on the B cells called CD19 instead of the CD20, and that looks very promising. And there's others in development as well, like odronextamab, as you see here below. Next. These bispecific antibodies, however, they do have unique toxicities, and they have to do with activating the immune system. So basically, when you activate the immune system, the patients would feel as if they have an infection. Now, they don't have an infection; it's their immune system fighting the cancer cells. But they'll get a fever, which is the most common. But they could also have other side effects, and we call that cytokine release syndrome, which is pretty much inflammation in the body from the T cells killing the cancer cells. Not common at all with bispecifics, but more common with CAR T is neurological toxicity, confusion, tremors. It can be severe sometimes, but that is rare with bispecific antibodies, and that is reversible with CAR T cell therapy or bispecific antibodies. in all patients pretty much. Other side effects, infections, low blood counts, fatigue, and diarrhea. These are also common side effects. Next. And this is just the cytokine release syndrome, which I wanted to include here. Basically, it's inflammation in the body. So patients again could get a fever. They could get low blood pressure, oxygen levels could drop, and that's if it's severe enough. But we do have medications that can reverse that. And sometimes that's why we need to keep the patients in the hospital for a brief period of time to observe them for these toxicities. Next. Neurological toxicity, as I mentioned, is another side effect, and it could be, a lot of these symptoms. But with bispecific antibodies, again, they're rare and they're generally mild. They're usually self-resolving within a few hours. And if they happen, they typically happen within the first cycle. Same thing with a CRS as well. If it happens with the first cycle, and both are reversible. Next. So given those unique toxicities and need for observation, we had an initiative here at Moffitt where we built we're in the process of actually expanding this as well, the SONIC program. Now, this stands for Specialized Oncology Non-Cellular Immune Therapy Comprehensive Care. And I'm going to give credit to Dr. Lancet here, who came up with this acronym. Next. So the SONIC service right now houses patients for many disciplines, because bispecific antibodies are not just in lymphoma and multiple myeloma, but again, there is patients with lung cancer now that are getting bispecific antibodies. There are patients with melanomas who are getting these as well. So the SONIC service houses patients for multiple different services at Moffitt, where patients get admitted to the service for observations for these unique toxicities by a specialized group who understands these toxicities and how to manage them. Once they're past that, first or second cycle where these unique toxicities typically happen, then they go back to their respective services. Next. That's a multidisciplinary team with a lot of details. It includes a lot of coordination. Obviously, it's very complicated because we have to coordinate with a lot of different departments that work very differently. We have to get, the schedulers, the financial clearance unit working together, physicians, pharmacists, nurse practitioners, infusion schedulers, nurses, the inpatient team, the outpatient team, the triage, the people who get those phone calls, night coverage. So a lot of moving parts to, developing this service. Next. So right now we do have the inpatient unit. We have recently also started to include patients on bispecific antibodies, getting them on a clinical trial. So we're treating now those patients on the SONIC service. We're training, more providers because the volume has been increasing over the last couple of months, given the new approvals. What we're looking for is to expand this to also the outpatient space. Obviously, we still need, space to do that. And we need to hire people in the outpatient space to do these things. We need to build a unified triage system. So, all patient calls from the outpatient, when they call, they go to one place instead of going to different, clinics, so just to have a more homogeneous service. And we're looking also for a dedicated night team coverage for that service. So again, we just started it in September of last year. It's been growing and working very well so far, and we continue to expand this. Next. So that's it for my part, and I'd be happy to answer any of the questions at the end.
Yeah, thanks so much, Sameh. That was outstanding, and it's pretty remarkable to think about how these new immunotherapies have really transformed the landscape of therapy in lymphoma, from what we used to do as purely chemotherapy to now sometimes a purely immune therapy type of treatment program. So really excited about the work that you and your group is doing to really support this type of immune therapy platform. And it's nice to see also that we've sort of crystallized this really cohesive structure for taking care of patients who go on to immunotherapy treatments, both standard of care and clinical trials, into services dedicated to these patients. So our program is really at the cutting edge of providing the care for these patients that are getting these novel therapies. So thanks for all you're doing. And I also recognize that I'm being relegated more and more into the role of coming up with catchy nicknames and acronyms for programs while everybody else is doing the real work. So I guess that's one of the perks of my job. But moving on, in going back to the theme of precursor states, I'd like to introduce another outstanding faculty member here in our department of malignant hematology, and that's Dr. Ariel Grajales Cruz. Dr. Grajales is an assistant member in the myeloma section, and he's done some great work in the field of immunotherapy, but also has an interest in precursor states. And multiple myeloma may represent the field of precursor states that is best understood in terms of natural history and risk factors. And I think that presents an outstanding opportunity to develop novel therapeutic and preventative strategies for these precursor states. So Ariel, thanks for coming, and please go ahead.
Awesome. Thank you so much, Dr. Lancet. And like he was saying, Ariel Grajales, I'm a faculty member here in the myeloma section, and I have a special place in my heart for these disorders, especially precursor states, right? As Dr. Lancet was mentioning, we have a great interest in this area, especially because when we talk about multiple myeloma, we're essentially simplifying a very broad disease altogether. Nobody starts with multiple myeloma overnight, right? This is a disorder that evolves over years and decades. And the definition of myeloma is having an actual cancer, right, that has symptoms per se, right? We can go to the next slide. And those symptoms actually come from an acronym called PrEP, right? High calcium, renal injury, meaning kidney problems, low hemoglobin, or bone disease. Precursor states, as you can see here, they actually linger for years and decades before they ever cause trouble in the patient. As you can see here on the left-hand side of this curve, this MGUS or smoldering myeloma situation happens over years. And it's only in a fraction of the patients that they're going to encounter an issue with myeloma per se, having an end organ damage. So basically a consequence from this deposition of monoclonal protein in the marrow. We can go to the next slide. The definition of this is very simple: symptoms, right? So on the left-hand side, we have MGUS or smoldering myeloma, and the distinction is purely numeric in nature. The size of the monoclonal protein, the presence of so many plasma cells in the marrow. But on the right-hand side, you can see that the patient is actually having symptoms caused by these disorders. And that's why it's so important to understand that when we tackle myeloma, we as treating physicians, we're actually tackling too little too late, right? Because we already have a patient that found trouble. And that's why there's so much interest nowadays into tackling these precursor states that by definition are not cancer. And I'm going to show you some numbers to understand that although myeloma is a rare cancer, right? We're talking about only 1.8% of all cancers. We know that these 34,000 new cases of patients that are diagnosed with myeloma annually here in the United States, it's only a fraction of the millions of people that live with these type of disorders. We can go to the next slide. And here in red, you can see a very dramatic number: 12 million people living with these precursor states, right? So it's not a negligible number at all. We're talking about 10 to 15% of the population in the US over the age of 50 having a precursor state without knowing, because we don't have a screening test for this, which is, it's a shame, right? Because the prevention is the best way to minimize the consequences afterwards. But we know that these type of disorders are also extremely prevalent in minorities, Blacks and Hispanics, and maybe that's why I take this disease so close to heart, because being a minority, I know that we're being affected more and more by this. we have a higher prevalence. So it's very important for us to be able to accrue minorities in our studies, because that's how we move the needle a little bit, and this is how we improve the outcomes for this population, especially when we're dealing with an elderly population, right? We know that our survival is improving, right? The statistical life expectancy keeps improving, especially when we compare that to 30, 40 years ago. We can move to the next slide. And that's important, because being diagnosed with a precursor state does not guarantee that you're going to have a cancer. And you can see the striking difference between these two disorders, MGUS and smoldering. Only 3% of the patients with MGUS will actually turn into having myeloma at some point in their lifetime. So essentially, after 20 years, about 20% only will have that situation. Smoldering is higher, it's about 10% per year. So it's not 100, but definitely these are the population that can get into trouble, especially high-risk smoldering. Next slide. These patients with high-risk smoldering, we've actually looked at that data extensively throughout the past decade and trying to understand, does it make sense to treat smoldering, high-risk smoldering, earlier before trouble finds the patient? And we see, the long story short on these graphs, and I don't want to bore you with the details, but you can see essentially that the red curve, they tend to need treatment way before the patients that are just on observation. That being said, to get to these curves, it takes years and decades, because in myeloma, we have a great problem to have, and is that patients are living too long for clinical trial purposes. When you have a clinical trial that needs a follow-up over that is over a decade, it's a good problem, but it's still a problem, because then to get to that overall survival, are we really changing something in the lifespan of the patient by treating the disease early? And it's complicated, because myeloma, it's probably, and no disrespect to my colleagues, of course, it's probably one of the fields in oncology that has evolved the most in the past 10 years. We have more drugs being approved in myeloma than in any other cancer, probably. And so it's exciting to see, but who are we going to give credit to? The early intervention that happened when we treated smoldering 10 years ago, or the salvage therapies that we now have nowadays for the treatment of myeloma? Next slide. So I just showed you a trial of just one drug, Revlimid, that changed, of course, the overall survival and the remission time for this patient and the times to need treatment. We've even tried more intense trials. This trial was actually, we were a part of it, and here we were treating smoldering as intense as myeloma, right, with 4 drugs therapies in a fixed duration. And we can see that it seems that we have a better remission time. And you can see that that curve is actually quite flat, but it's not fully horizontal, right? And I think that's the piece that we're missing for these patients. It's great to have a longer remission for the patients that turn into myeloma, but are we really curing somebody? And the answer is not necessarily. We're just kicking the bucket down the lane. And this is with more traditional therapies, but we can go to the next slide. The Aquila was actually a trial that was presented at this very last hematology meeting in San Diego in December. And these once again showed something. There is a benefit in overall survival for these patients that are treated with immunotherapy, with daratumumab in this case. But these curves, are they completely horizontal? And the answer is still no. There is still some people, there are still some patients that do die from the disease. How are we curing these patients? And in reality, these early interventions with the current data that we have, it doesn't seem that is the case, but we have a great idea. We know that we can push the envelope and push, kick the bucket down the lane a little bit more, but how to get to that cure? And probably the key is in the novel therapies. Next slide. Because you can see here a bunch of studies that are being focused more in immunotherapies that are more exciting, right? We're talking about CAR T-cell therapies, bispecific antibodies, combination therapies with these agents. Because we have to remember something, single agent activity for these myeloma drugs, historically, before these T-cell engager therapies were available, was only 30%. Now we're seeing that single agent activities for the T-cell engagers and CAR T surpass consistently the 60, 70%, in some occasions the 95% of responses. So we know that these are better therapies. And with all these clinical trials that we have available in the right now, hopefully in the future, we're going to be able to say, you know what, this early intervention with these great therapies that we currently have can make sense. And we can now call a cure, not just a functional cure. Because right now we're being content with telling the patient, if you die of something else, that's a functional cure. I did my job of keeping you alive so that something else puts you in trouble. But is it enough? Right? Especially because we want to ensure that the patient gets the possibility of a fixed duration therapy. How can we treat the patient for an X amount of time and be done with it and have almost a guarantee of not having the disease come back? That would be amazing, right? Next slide. And this slide is the perfect example of how things have incredibly changed for us in myeloma. If you look, we've been doing transplantation for myeloma since 1983, so 42 years in the making. How are we doing this? For 42 years, we've had innumerable clinical trials trying to debunk transplantation and its role in the treatment for myeloma. 0 have succeeded. 0. I mean, this is literally the Mike Tyson for sure of myeloma drugs. But is it the greatest drug? No, it doesn't even change overall survival, right? It just changes the remission time. How can we get there? And you can see on the right-hand side that we have 3 very interesting products in blue: talquetamab, elranatamab, and teclistamab. These are bispecific antibodies that the one Dr. Gaballo was mentioning. And we also have 2 CAR T-cell therapies. We have cilta-cel and ida-cel in gray, both of them. And these are these exciting drugs that I was referring to. These might be the key to get to that real cure in myeloma by preventing the disease into getting active before we have end organ damage, just by tackling at the appropriate time. It's very important for us to really, number one, have these trials available from our standpoint, but 2, to have the patients willing and amenable to participate in those clinical trials. We need more samples. We need tissue. We need minorities participating in these clinical trials. We need we clearly need donations all the time, because this is very important to get to that cure, right? To our commitment of getting to the cure of cancer. And also, it takes sometimes very little effort to contribute to the cure, right? We have a very important clinical trial that is observational only. And it's not even for our patients. It's for the relatives of our patient. It's called the PROMISE study. And it's essentially to enroll any relative, any first-degree relative of a patient diagnosed with a plasma cell disorder like MGUS, smoldering, or myeloma, and to have them tested. And this is a national study that we're doing across the country, in which the patient, the only thing that they need to do is self-enroll in a QR code that we're happy to provide when you guys come to clinic. And essentially to get a testing kit, the relative goes to any lab of their preference. That testing is back to the main institution, and we determine whether or not there is a precursor state going on, because we want to understand whether or not there is a genetic component to this disease. We don't truly understand what's causing myeloma other than age and some environmental causes like Agent Orange from those veterans that served in Vietnam. But we don't know. We only assume that there's a 2-3-fold increase in the risk for developing myeloma when you have a relative with myeloma to begin with. And the other population that is extremely important to enroll in this PROMISE study is African Americans, because as I said, Blacks and Hispanics, we have a higher rate of developing myeloma. Any African American can enroll on this clinical trial. And that is a very good opportunity, because we want to understand what leads to causing this. Okay, and that's very important. Next slide. And that's it, guys. I just hope that my excitement for precursor states and getting to that cure transpires to you.
Thank you so much, Ariel. Great presentation, and it's really exciting to think about how we can learn from these precursor states and develop novel therapies that could potentially have much more of an impact if they're administered early on in a treatment course or a diagnosis than waiting until later on, as you mentioned. So just tremendous opportunities for clinical trials in this area. And I would also point out Dr. Grajales and colleagues are opening a precursor clinic in the myeloma space, an MGUS clinic in the very near future here at Moffitt in the next month or so that will be focusing purely on patients that have these precursor conditions. So a great opportunity to provide cutting edge care, but also for patients to participate in trials in this area. So with that, thank you. And I'd also like to just take a moment before we get to the Q&A session to introduce one of our partners here at Moffitt, and his name is Tyler Wilson, and he's on the line. Tyler is a major gift director here at Moffitt, and he partners closely with our program to help us maximize the amount of research dollars that we receive to do clinical research and to do translational research and really ultimately make advances in cancer therapy. And I can point to several examples of research dollars that have been facilitated by Tyler to help us launch important projects in, for example, one of Dr. Salman's database projects looking at prospective molecular testing in patients with myeloid diseases has been funded through the foundation. And we have several other examples of clinical trials and preclinical research also being funded through foundational and philanthropic funding that in large part is due to Tyler's great support. So Tyler, would you like to say a few words?
Yeah, absolutely. Thank you, Dr. Lance. And thank you so much to everyone for being on the call tonight. Yeah, I've been with Moffitt now for going on 5 years, and it's truly been an honor to be part of this team and to really see the advancement that has happened just in the course of that short 5 years. Dr. Grajales' slide at the end, just focusing on multiple myeloma, just to see the number of advancements that have happened in recent years. And across the board, from all the topics discussed by our wonderful presenters tonight, philanthropy has had an impact at each one of those levels. And I think what makes Moffitt unique really is the institution's investment in all of these initiatives that we have here. And then you pair that with our wonderful partners in philanthropy. And it truly makes a difference. No matter the size of the gift, we can take a gift designated for malignant hematology across the board, or you can make a gift specific to each one of the sections discussed tonight. And those gifts can be paired with other gifts with those types of designations and really make a cumulative impact on some of the highest priorities across the department here. And a lot of the initiatives that were shared by the team here can really see an impact by the generous support that we receive. So thank you so much for everyone for being on the call today. If you have an interest in learning more about how philanthropy can make a difference, or if you'd like to learn more about making a gift to a specific area at Moffitt, my email and phone number are listed. I'd be happy to discuss any questions that you might have. And thank you again for being here tonight.
Thank you, Tyler, for all the great work you're doing to support malignant hematology research here at Moffitt. So we're going to enter into the Q&A session right now, and I would invite people to go ahead and submit questions into the Q&A box that we will attempt to answer to our best ability. And we may not get to every question, but we'll try to get to as many as we can here in the next 15 or 20 minutes. Let me start out by posing a question to Dr. Gibala. The question is, are there any new advancements, studies, or trials related to the treatment of chronic lymphocytic leukemia, specifically atypical CLL?
So yes, we do have, there's like a lot of clinical trials being done in CLL. CAR T-cell therapy got approved very recently, a few months ago, last year, in CLL. Bispecific antibodies are not yet approved, but there is ongoing clinical trials in patients with CLL. There's also, other novel BTK inhibitors that are being looked at in CLL. Dr. Javier Pena here leads one of these clinical trials here at Moffitt for patients with relapsed CLL. Now, atypical CLL, this specific term is not going to have a one trial targeting that specific group of patients because that's an uncommon group, and usually, they could be, They could cross over between different entities, including marginal zone lymphoma, CLL. So typically clinical trials will not specifically, look for patients with atypical CLL.
Thank you so much. Let's move to Dr. Salman. There's a question about any new therapies on the horizon for myelofibrosis.
Yeah, so I think, we had this one trial that I mentioned briefly, very close to the finish line. And again, we're trying to lead efforts to kind of resurrect that. But at the same time, there's actually a lot of exciting trials. So basically, instead of just adding two drugs from the get-go, potentially the best group is patients that suboptimally respond. Maybe those are the patients we should add something, and then it'll be a much more clear signal that the combo is better than one agent by itself. So there's a pivotal phase 3 trial with an MDM2 inhibitor called navtemadlin that's now opened at our center. Similarly, unfortunately, JAK inhibitors run their course in nearly all patients. And so what to do after that? So one, I think, really exciting therapy with a company called Ajax is a JAK selective inhibitor. And this may actually lead to complete clearance of the mutation and also have less side effects. So we're testing it first in relapse, but I think it'll be a no-brainer if that data is exciting that this will move more towards the front line. And then maybe lastly that I would mention is again, we're hearing all about this amazing immune therapy by my myeloma lymphoma colleagues. One of the mutations, which is about a third of myelofibrosis and can occur in other myeloproliferative mutations called CALR or calreticulin, is targetable. This has been proven preclinically. And so we're opening probably this next month, the first trial with a bispecific antibody targeting CALR. And there are some aspirations to potentially bring a CAR T that's probably more in 2026. So I think those two, and then maybe lastly, imetelstat, which we talked about, is approved for MDS. We have two trials, both as a frontline combo and as a salvage option in relapse that are open. The cool thing about the salvage option is the first trial ever in myelofibrosis to have OS as a primary endpoint. And I think we really need to start moving to that, and not really having sort of the same me too endpoint. So I think a lot of exciting things going on in the myelofibrosis space.
For sure. Thank you, David. I wanted to move on to a question for Dr. Grajales, and I think this is pertinent to kind of understanding the landscape of therapy. But the question is, what is the average amount of time in general for myeloma patients to require CAR T therapy after a stem cell transplant? So obviously we're using a lot of immunotherapy after autologous transplant. I guess the question is, what can we expect in terms of the timeline between transplant and CAR T, and maybe how effective it is after transplant?
Perfect. That's a great question. And actually, before that, I want to address another question that I typed the answer for PROMISE study. The information, you simply go to www.enroll.promisestudy.org. I typed already that site, but that's for anybody who wants to be interested in that. In terms of the sequencing, right, for CAR T, so nowadays we have two CAR T products approved, ide-cel and cilta-cel. They're approved for third-line therapy and second-line therapy, respectively. It's not a matter of timing, as a matter of fact. It's just a matter of for how long does the first response is sustained. Okay, so if you have a patient that gets any type of induction, 4 drugs, 3 drugs, whatever the case might be, transplant, and then lenalidomide or Revlimid maintenance, and the disease gets active again, that patient can get into cilta-cel for CAR T. However, the patient has to be lenalidomide refractory. That's the only requirement by the FDA, to be refractory and to be lenalidomide exposed and refractory to it. So it has to stop working. So it's not so much a matter of timing, it's more a timing of what's working and what's not. We do have a clinical trial here at Moffitt for newly diagnosed, so patients with newly diagnosed myeloma, comparing head-to-head transplantation to CAR T-cell therapy. So a great way to get the opportunity of receiving CAR T-cell therapy frontline would be through that clinical trial, and we would be more than happy to see you guys in clinic for whoever is interested.
Sorry, I was on mute.
Yeah.
I apologize. I wanted to go to Dr. Gabala for a question that related to how long can we expect these bispecific antibody therapies to work? And I think that's an important question in the sense that they're often used as kind of treatment down the line after, initial therapy.
Yeah, so these antibodies typically, if they work pretty quickly. So you're gonna know after 1 or 2 cycles if it's working, and we typically get another scan or so after 2 cycles to see the response. But they work pretty quickly. There's also another question here, which has to do with how many lines of therapy do patients need to have had before they could get bispecific antibodies. Obviously, right now we're having clinical trials in the first line as well as in the second line, but in terms of FDA approvals, it's currently FDA approved for patients who have had 2 prior lines of therapy.
Thank you. We have an interesting question that I'll try to answer. It's, as AI, artificial intelligence, becomes popular, in what ways does the Malignant Hematology Program plan on using this technology? I can tell you that it's a Moffitt-wide initiative and a project that's actually just taking off right now, where we are partnering with the machine-based learning program to develop algorithms for treatment based on artificial intelligence across all malignancies. So it's going to be a really exciting time to utilize AI in the setting of decision making. And I fully envision that within the next couple of years, we will have AI tools to help us determine the best possible treatment for any given patient at any specific time based on what is a wealth of information in our database. Our department has some of the best databases in the entire center, with very highly annotated details on every patient-specific factor, clinical, biologic, you name it, and that's going to really facilitate the use of AI to help us in our decision-making process. So stay tuned for that. That's really an organizational-wide initiative that's being launched this year. Let's see here. Let me just move to a question. Dr. Salman, there's a question about MRD evaluation in TP53 mutations, and maybe you can comment on how we are utilizing MRD in general for myeloid malignancies and how it's driving decision making.
Yeah, so I think broadly, MRD is probably the most important, really change in how we're managing our patients. And it's not just prognostic, which we've known for multiple years, but we can actually do multiple different things to intervene and to improve outcomes and to really ultimately prevent the relapse. The agents that we've really seen the most data to date are mostly with targeted agents, where if we can pick up the mutation, we can start agents, even with our brand new class of agents, revumenib, for NPM1 KMT2A rearrangements. There's some early data that initiating with molecular MRD, you can actually ultimately prevent the relapse. But to the TP53 specific question, what we really recently presented at ASH was it's probably the most relevant biomarker to predict relapse in patients who go to stem cell transplant, which is our only curative therapy. And so I really think for really any post-allo strategy, having P53 MRD will probably be the key early endpoint to look at this. I think to the point of the question, what about in patients who can't go, which unfortunately is a significant percentage of our population? I think as we're finally starting to enroll P53 specific trials, it can be really hard to know from a response rate, is this effective, is it not? And so potentially looking at P53 clearance may be our best early predictive biomarker for strategies that should go forward with more pivotal agents. And I just wanted to comment on one other question live briefly, because I'm going to have to leave to pick up my middle daughter, is that for CMML, which somebody brought up, we actually probably have the world's largest trial portfolio for that group, and I've actually treated more CMML patients. This is a lot been led by Dr. Padron, who's truly a world expert, but Dr. Zoe Shi also is focusing a lot of trials. So we're looking at those JAK inhibitors to eliminate the inflammatory disease states. And then I think potentially more exciting, we have actually the first in human trial ever specific for CMML. This is targeting a chemokine receptor called CCR2. And Eric's going to be doing a lot of the translational work that we will enter trials in 2025 for relapsed CMML, as well as some other exciting combination and inflammation targeting strategies. I just wanted to briefly mention that, but thanks for having me here, guys.
Thanks, David. Really appreciate it. we'll go through a few more questions here. One is that let me pose it to Dr. Grajales Cruz. There's a question about whether CAR T therapy could be used, and maybe this applies to other immunotherapies as well, prior to kind of last in line, last ditch effort. Can we consider therapy with CAR T earlier in myeloma? I know it's already being done in lymphoma, but in myeloma, what are your thoughts about that?
Yeah, absolutely. I think, as I mentioned earlier, the most exciting part in treating myeloma nowadays is these novel therapies, right? And so we're trying to get these CAR T products to early lines. Currently, it's second and third line. But to the question regarding can we do it if the therapy is no longer tolerated, the answer is no. It's only upon progression of the disease, right? So like I said, you have to be on Revlimid, and if you're not on Revlimid, you're not on Revlimid because you could not tolerate it. That does not count. The FDA label is it has to stop working, the Revlimid per se, and essentially it's because these products do not come free of side effects. There are some significant toxicities like that Dr. Gaballo was mentioning, CRS, ICANS, as well as delayed neurotoxicities, secondary malignancies, etc., that we always have to discuss with you guys so that we can make a better decision as to what's to come. But we most definitely want to see these novel therapies moved up front, and that's why we always encourage the participation in clinical trials like the one that I mentioned, CARTITUDE-6, that is comparing the traditional transplant, right? The good old chemotherapy, like Dr. Lancet was mentioning, versus the novel therapies, these nuclear bomb versus sniper. That's a good way to see it, essentially.
Thank you. Let me ask Dr. Gabala a question. There's a question from a young lady asking about clinical trials for Hodgkin's disease, I believe, and maybe you can address our portfolio in Hodgkin's, but also in general how we're doing with clinical trials in younger patients and adolescents in the lymphoma field, where the incidence is certainly higher for younger patients than in the myeloma or myeloid field.
Yeah, so I believe her question is specifically about nodular lymphocyte predominant Hodgkin's, which is a relatively rare type of Hodgkin's lymphoma. The trials that we have at Moffitt right now are for the classical Hodgkin's lymphoma. But in terms of nodular lymphocyte predominant Hodgkin's, these are actually more like follicular lymphomas than they are as Hodgkin's lymphoma. And they treat it very similarly to follicular lymphoma. But they usually don't have, specific clinical trials addressing this group. This group of patients usually do very well with follicular lymphoma-like therapy.
Wonderful, thank you. And I think probably at this point, we're gonna close the webinar. We've had some great questions and some great presentations and discussions. I hope that Tyler and Brielle and Stacy can communicate with us any outstanding questions that people still have in the chat box that we can answer offline. But I'd like to just close by thanking all the outstanding speakers, Dr. Grajales, Dr. Gabala, and Dr. Salman, for really outstanding overviews of the research and clinical landscape in our diseases. We're really proud of the work that we do, and really grateful for the opportunity to take care of patients with these challenging diseases. So thank you guys for all that you do and for being on the line tonight. I'd also like to thank Tyler for all of his support of our department in the area of philanthropic and foundational support. It's been instrumental to what we do and what we will be doing, moving our field forward. And then just a big shout out to Brielle Humphreys and Stacy Price, who put a lot of work into this webinar tonight. Thank you guys so much for organizing this. It's a big deal. It's important that we really communicate with our patients and our community about the work that we're doing to raise awareness of the difficult diseases that we see and really the need for as much interest in the community that will lead to moving the needle with advancing therapies and getting as much financial support as we can through awareness. So thank you guys for putting this on every year. You do all the work. We just come on and talk. But all the behind the scenes work is done by Riel and Stacy and Tyler. And with that, I think we will close another successful session, and we will do it again next year. And I'm sure a lot of people online are also patients or families of Moffitt patients, and happy to answer questions down the road and communicate offline as well. So thanks everybody for coming, and have a great evening, and wishing everybody the best. Thanks.